And it's about, look, no surprise, it's about pulmonary embolism, which we've talked about before. More specifically, the imaging of PE and what can go wrong. So, 35-year-old female, she comes in, pleuritic chest pain, she's short of breath, she's tachycardic, worried. I don't find another diagnosis. I ask her about her ankles and I ask about her legs. Yeah, they're a bit swollen, doctor. So I'm like, okay, what the hell? I'll do a CTPA, find that PE, because that's what I'm worried about, right?
Let me guess, was it negative?
Yeah, it's negative, yeah. So how many times has that happened to you?
Yeah, look, it happens. I think that's part of our job, isn't it? We think worst case scenario.
Yeah, exactly.
But I don't know about you, the last time I was on the floor, we've got over 20 people waiting for CT scans.
Yes.
It's just full. We've got a real problem.
So there's a cost, right?
Yeah.
There's a cost to CT. The cost is the actual monetary cost. There's the production line cost because it slows things down. And there's also the radiation, obviously. But is there another cost?
Yeah, I think there's a sustainability issue there too.
Sustainability. I don't know nothing about that, but luckily we have our expert, Kiva, so welcome.
Thanks, John.
You're going to talk to us about sustainability and CT scans and PE, is that right?
Yeah, that's right. So I guess sustainability, as you pointed out, is really important. We know that climate change is the biggest threat to healthcare in the 21st century, and the United Nations and the Lancet and the BMJ and all these publications have been shouting about it for a couple of decades, and healthcare has a lot to answer for. We're about 7% of all the carbon emissions for Australia is the healthcare sector, and so reducing...
What? 7%?
Yeah.
Of all carbon emissions for Australia. So to put that in perspective, all cars are about 10%.
Oh my God.
I know.
So
and think of all the things we do to reduce our cars, like we bike to work, we carpool, and there's electric cars, and
so that's frightening.
Yeah.
So we need to do something about it. So what's the deal with CTs? You did a study, I think.
Yeah, so we did an audit of the CTPAs done here at Royal Melbourne looking for PE, and we're trying to see if people are using clinical decision rules and if some of these CTs could be unnecessary. About 11% of the CTs that we do are positive for PE, of the CTPAs are positive for PE. And
1 in 10.
Yeah, 1 in 10.
Yes.
Yeah. And we know
so
from
mine was not in that category.
No, yours is in the 90%.
I didn't actually use the rule. I mean, can I just check?
Did you use the rule? Did you use the scoring?
It was kind of Gestalt kind of rule. I did think about it. I thought about the wells. And I thought, tachycardia, and I thought maybe DVT, and I thought that got me across the line. And then I also thought, well, is there a better diagnosis? And I think that gives me something else as well. So I thought I was at a moderate risk, like in the back of my mind, maybe I'm wrong. Do you use that?
I do use it, yeah, but it's a lot of it's open to interpretation. So what is a DVT clinically? Is it just a little bit of swelling?
Exactly. Yes.
And so I think it's very clinician dependent. What do you think, Cleva?
Yeah, I mean, only about 11% of the people who order CTPAs are using or documenting that they're using these clinical decision rules.
Yeah.
And I think on the wells there are 3 points for PE being the most likely diagnosis. You can always add that in. But your patient would have had a score of 4.5, making them moderate, qualifying them for a D-dimer.
D-dimer. So that was the thing. I should have probably, because if I remember rightly, so mild and moderate, I can do a D-dimer, and I can get out of jail, get out of a CT. If it's a severe one, if it's a high risk, I'm just going straight to CTPA.
Correct.
Yeah. That's how I've been practicing. But maybe I haven't been writing it down.
So we've got a really easy pathway on our EMR now at Royal Melbourne where you can just tick work up for PE and it will come up with your well score to help you calculate it and then suggest either a D-dimer, which you can use age-adjusted rules for, or proceed straight to CTPA for
that's
risk.
Great. So that'll take the guesswork out of it. If I could use the system, that'd be good.
With the D-dimer, Cleva, can we use age-adjusted D-dimers?
Yeah, so they're well validated and we know that they're really safe to use. So age-adjusted, as I'm sure everyone knows, just being you add a point in front of the patient's age. So rather than 0.5 being our cutoff for everyone, if the patient's 60 years old, it can be 0.6, and so on.
Yeah.
That's good. That's really great.
And is there a lower age for that, the age adjusted? Or is it like...
No,
I think it's
just all 0.5 for everyone under 50.
Yeah. All right.
So
Okay.
what are we looking at in terms of if we can achieve a reduction in CTs? Like, give me some positive news about the environment.
So, I mean, if we do about 150 CTPAs a month for PE, and with only about 11% of those being positive, we know from some big studies, Respect ED, done in 13 EDs across Australia, that we should be aiming a bit higher than that for about 17% of our scans to be positive to still be safely doing the right
So
amount
that was
of
what they
scans.
found in that study.
Correct.
Yeah.
And so if we can reduce our relative reduction in the CTPAs by about 20%, then in a year we could save about $220,000 for our department alone, which would be a lot, but also about 450 kilograms of equivalent CO2 emissions, which is about 37,000 charging your smartphones, which is quite a lot.
Wow, gee.
And also, as you mentioned, reduce length of stay in ED for our patients, reduce the exposure to radiation, contrast, those type of things.
It would really improve our access block and crowding.
Yeah.
Absolutely.
Yeah.
So the solution is what? Use the rules. Use the guides.
The solution is use the clinical decision rules. We're not asking anyone to really change practice. It's just to use those rules. PERC and WELS that have been there for, longer than I've been a doctor and are really well clinically validated. That's what we're encouraging.
That's great.
Sounds good. So, Jana, you're going to use the rule next time?
I will.
You
And
can remind
I will
me next time.
document it in
Yeah, and
minutes
document
to
it.
justify
I think-
my decision.
Yeah, I think that's it, isn't it? I think I think about it.
Mhm.
I don't always document it.
Yeah.
So,
And I think
yeah.
what we all are a little bit guilty of is picking bits of, each rule, like same with when we do C-spine,
Yes,
what
yes.
suits you,
Yes.
and kind of putting a lot of weight onto one aspect
Yep.
of the history. We
Yep.
should just take a step back, look at it objectively,
Yep.
And do the right thing for the patient and the planet.
And the planet and the
Yeah.
environment. Sounds great, Kiva. That's going to be so exciting. Let's hope that next time we talk, we've made that reduction.
I hope so. That's
yeah.
the plan.
All right. Well, thanks for coming.
Thanks for
It's
having
great
me.
having you. See you, everyone.